Good morning and welcome to today's lecture. Today we are discussing chapter 53. This is care of the patient with a sensory disorder. Okay, so let's start with an anatomy review. The eyes consist of the eyeballs, which are globes that sit in a protective bony cavity called the orbit. These bones help form the wall of the orbit. The eye contains muscles known as the extraocular muscles, and these permit the eyes to move. There are also three cranial nerves, also known as the extraocular muscle or the EOM, and these consist of the trochlear, the abductus, and the oculomotor nerves. There are extraocular structures. These structures are outside of the eyeball itself, and they help protect the eye. So we have the eyelids, eyelashes, and tears, and they protect the anterior or the exposed surface of the eyes. The lacrimal apparatus drains tears to keep the eye moist and sweep away any debris in the eye. And the conjunctiva is a very thin, transparent mucous membrane that lines the inner aspect of the eyelids and the anterior surface of the eye. So let's move on to the inside of the eye, or the intraocular structures of the eye. So there are three layers that comprise this part of the eye. We have the sclera, the uvea, and the retina. And so these are what the three layers are. The sclera is the white of the eye, and the cornea is the central anterior portion of the sclera. The uvea consists of the choroid, iris, and the pupil. The retina is the innermost layer of the eye, which is composed of a pigment outer layer and an inner neurosensory layer. So within the retina lies the rods and the cones. Rods help distinguish black and white and function in night and dim lighting. The cones function in bright light and is sensitive to colors. The macula lucida lies in the center of the retina and is comprised entirely of cones and allows for detailed visions. So it provides us with central vision that we need for reading and seeing images and details. The function of the eyeball is to convert light energy into nerve signals that are then transmitted to and interpreted in the cerebral cortex. In order for this to occur properly, the reflected light must pass through the intraocular structures. There are four basic processes that occur to form an image. The first is refraction, the second is accommodation, and the third is constriction, and the fourth is convergence. Refraction occurs when the eye is able to bend light rays so that the rays fall into the retina. Accommodation is when the eye can focus on an object at various distances. Constriction is when the size of the pupil, which is controlled by the dilator or constrictor muscles of the iris, and that regulates the amount of light that is entering the eye. Convergence is the medial movement of both eyes that allows light rays from an object to hit the same point on both retinas. So remember that when you're doing an eye assessment, that this is a focused assessment, just like you would do a physical assessment, but you're focused on the person's eye and their vision. So you're going to ask them a series of questions to find out what brought them to the physician, or what problems they're having with their eyes. Do they have any eye pain? Do they have any itching? Do they have any sensitivity to light? Excessive tearing, dryness, floaters, light flashes, halos, diplopia. Are they having any discharge or drainage from their eyes, or any visual changes like in their peripheral vision or their depth perception? Is the patient complaining of any headaches, myasthenias? What current medications are they taking? Are they taking any medications for any high blood pressure, that kind of thing? Because sometimes it could be a side effect of a medication, and that's what they're experiencing with their vision. Do they use any visual assistance devices? Do they wear contacts? Do they wear glasses? Do they wear readers? Do they use a magnifying glass? Do they use any devices with that? And what are their personal habits related to their eyewear? So if they wear contacts, are they cleaning them properly? Are they cleaning them like they should, removing them as they should? When they're having their glasses, they're keeping them clean, free of any debris or anything like that? And have they had any eye injuries in the past or any eye surgeries in the past? So remember, an eye assessment is just like a physical assessment, but it is more focused, and it's focused on the person's vision. So pupil assessment is something that you're familiar with. You do this when you do your physical assessment. You check the size of the pupil, and it should be anywhere from 2 to 4 millimeters in bright light and 4 to 8 millimeters in dark light. And you see that the scale at the bottom of the page here to show you the size of the pupil and how it dilates. And it should be normal in size when you look at it. They should constrict and dilate equally when they're exposed to light. And when you do your pupil assessment, make sure that you record that or document that assessment findings. So you want to document your PERLA. Are the pupils equal, round, reactive to light, and accommodation? So make sure that you are documenting that properly when you're doing that pupil assessment. So whenever you're doing your eye assessment, you're focusing on the abnormals. So you're looking for something that you don't expect to find when you're doing your typical assessment. So some of the abnormal findings you may see is drooping eyelid, which is ptosis. Protruding eyelid that delays closing is proptosis. And exophthalmos is the protruding eyeballs that you may see sometimes with myasthenia gravis. Nystagmus is an uncontrolled oscillating movement of the eyeball. So here's a YouTube video that's embedded on this PowerPoint that you can go in and take a look, further look at these assessment findings. So when we are testing someone's visual, or we're doing a visual screening as they call it, we're going to be using a Snelling eye chart. And the Snelling eye chart determines visual acuity, and that is the ability to see far images clearly. So the chart is usually set 20 feet away. It assesses both eyes and then each eye separately. 20/20 vision is considered to be normal vision. Next, we may use the Jaeger chart or the Rosenbaum pocket visual screener, and that evaluates the near vision. So the chart is held about 14 inches away, and the size of the print the patient can read indicates the quality of their near vision. So whenever we are testing the muscles or the extraocular muscles, we're actually looking for the corneal light reflex that shows us the alignment of the eyes. So when we take our pen light and we look, have the patient stare straight ahead, we're going to see if the light is in the same spot on both eyes. On the top picture, you see that the light is reflecting in the same spot in both of the eyes, but if you see in the bottom picture, you see that the light reflection is off a little bit and it's not in the same spot. So whenever you have that uneven alignment, it can indicate a muscle weakness or even paralysis. Another way of testing the EOM function is to do the cover and uncover test. The patient stares straight ahead. One eye is covered with an opaque card. While covered, you check the uncovered eye for any movement. Uncover the other eye and then observe for any movement in that eye. Position test, we're looking at the cardinal field of gaze. The patient focuses on an object about 12 inches away, and moves the object through the 6 cardinal fields in a clockwise direction. Asymmetrical movements indicate EOM weakness or dysfunction of the cranial nerves. Refraction refers to the bending of light rays as they enter the retina. Sometimes refractory errors can be corrected with either lenses or surgical intervention. Astigmatism is the defective in the curvature of the eyeball surface. Exotropia is a form of strabismus where one or both of the eyes turn in the direction of the nose. Extrophia is a form of strabismus where one or both of the eyes turn outward away from the nose. Hyperopia is farsightedness. Myopia is nearsightedness. Strabismus is the inability of the eyes to focus in the same direction. Here are a few more terms that you need to be familiar with. Emmetropia is normal vision, and this is when parallel light rays are focused on the retina. Myopia is the nearsightedness, and that is parallel light rays are focused in front of the retina, causing difficulty focusing on distant objects. Eyeballs are elongated when compared to normal. Hyperopia is farsightedness, and the eyeball is abnormally short. Parallel light rays are focused beyond the retina, and images become blurrier as they become closer. Presbyopia is associated with aging and results in near vision, gradually loss of elasticity, and the lens are leading to a more difficult focus. There are several pieces of equipment that we use for eye exams. The most common is the ophthalmoscope, and the ophthalmoscope examines the fundus of the eye. It illuminates the internal structure of the eye and allows for optimal visualization. The retinoscope is a handheld instrument that produces a line of light which will appear distorted if there is any refractive errors that occur. The tonometry measures the intraocular pressure and helps screen for glaucoma. The Amsler grid is a geometric grid of identical squares with a central fixation point, and this identifies macular problems. The squares will appear faded or wavy to the viewer. The slit lamp is a binocular microscope that magnifies the surface of the eye. It aids in identifying surface abnormalities like corneal abrasions and cataracts. The retinal angiography detects vascular changes in blood flow through the retinal vessels. The IV dye can cause yellowing of the skin and bright yellow urine for up to 36 hours after the procedure. Eye safety measures. Do not rinse eyes with unprescribed solutions. Discard any ophthalmic solutions that are cloudy, discolored, contains particles, or has been opened longer than 3 months. Avoid eye strain. Always use good lighting, especially when you're reading. Wash hands after touching your eyes, especially if you have some type of eye infection. Wear safety glasses where eyes can be injured. Flush the eyes immediately, 15 to 20 minutes minimum, with cool water or saline when irritating substances are introduced, such as some type of chemical or something that's in the eye. Wear dark glasses for prolonged exposure to bright light. Do not attempt to remove foreign bodies from the cornea. Always cover the eye with an eye shield if there's a foreign body there. If dust blows in the eyes, pull the upper eyelid over the lower and let the tears wash the speck into the inner canthus where it can be safely removed. Encourage periodic blinking to clear dust and particles from the surface of the eye. So that blinking action helps slide that debris to the center of the eye where you can get that out from the inner canthus. Replace any eye makeup every 3 months and do not share eye makeup. The first eye disorder that we're going to be discussing is blindness. Blindness is a loss of visual acuity that ranges from partial to total loss of sight. Legally blind is defined as individuals with a maximum visual capacity of 20 to 200 with corrective eyewear and or a visual field sight capacity reduced to 20 degrees. Signs and symptoms is diplopia, blurred vision, eye pain, presence of floaters or flashes of light in the visual field, light sensitivity, burning of the eyes, loss of peripheral vision, and halos. Corrective eyewear is the first method of management for blindness. Medication if the blindness is a result from an inflammatory disorder. Assistive devices such as guide dogs, canes, magnifying systems, computers, telescopic lenses, and braille can also be used. When assisting a visually impaired person, you should precede the person by about 1 foot with the patient's hand on your elbow. Corneal transplants may also be used to restore vision. When communicating with the visually impaired, announce your presence when you enter the room. Talk in a normal tone of voice. Introduce yourself with each contact. Explain any activity occurring in the room. Announce when you are leaving the room, and promote independence. We can do this by identifying them, by notifying them of the placement of objects in the room. We can describe location of food on the tray, have them independently place their hands on the tray, and orient themselves to the placement of the food. Refractory errors. Refraction errors are visual changes. These are corrected by corrective lenses or surgical intervention. Most common are astigmatism, strabismus, myopia, and hyperopia. Myopia is the nearsightedness, and that's when you can't see distant objects clearly. Corrective lenses can fix this. May also be corrected by laser surgery. Candidates based on the severity of the myopia and underlying medical conditions. LASIK is the most common surgery. Patients will need an eye patch post-procedure until the next morning, then vision typically will quickly improve. Hyperopia is farsightedness and they can't see objects close up. Treatment is corrective lenses, sometimes even over-the-counter reading glasses. Inflammatory and infectious disorders of the eye include blepharitis, inflammation of the eyelid margins around where the lashes grow, and this can be a bacterial infection, typically staph. Sometimes it can be caused by psoriasis or allergies. Signs and symptoms include excessive tearing, matting of the eye, itching, redness, and pain. Chalazion, which is an inflammatory cyst. Lots of times this occurs in the eyelid margin, typically blockage of the oil gland, and it is a potential complication from a sty. Signs and symptoms are discomfort, mass on the eyelid, edema, and visual disturbances. A sty is an acute infection of the eyelid margin or the sebaceous gland of the eyelashes. Frequently it's caused by a staph organism. Signs and symptoms include abscess, localized to the base of the eyelashes with edema of the lid, warmth and redness, tenderness and pain that may diminish after pustule ruptures. You may have tearing, blurred vision, scratching sensation of the eye. Treatments should be warm soaks to ease the symptoms. No medications are required. Conjunctivitis or pink eye is an inflammation of the conjunctiva. It typically starts in one eye but can easily infect the other. Most common bacterial infection, but sometimes viral sources can also exist. Trichomia is a highly contagious form of conjunctivitis and is caused by a strain of chlamydia. It's rare in the U.S. but major causes of blindness in other countries. Signs and symptoms of conjunctivitis is erythema to the conjunctiva, edema of the lid, purulent cresting discharge from the eyelids and the cornea. It can progress to scarring and vision loss if untreated. It's usually treated with topical antimicrobials, and educate the patient that this is highly contagious. Keratitis and corneal ulcers. Keratitis is an inflammation of the cornea. Corneal ulcer is an erosion of the corneal tissue. Keratitis and corneal ulcers are generally caused by trauma, contact lenses, which are typically worn incorrectly or too long without changing, infection and exposure to contaminated water, immune compromised periods or long use of steroids. Assessment findings: localized pain or sensation of foreign body is present. Blinking typically makes it worse. Photophobia, blurry vision, tearing, and purulent discharge and redness. The treatment for keratitis and corneal ulcers generally is typical anesthetics, myodratics, local and systemic antibiotics, dark glasses to relieve the photophobia, or an eye patch. Nursing management should include advising the patient to stop wearing the contact lenses temporarily until the infection clears up. Assist with the administering of eye medications carefully using aseptic technique. So you should have to teach your patient how to administer those eye drops. Ask them how they're administering the eye drops. Make sure that they're using clean aseptic technique when they're putting those eye drops in. Remember, you don't want the dropper to touch the eye in any way. A common lens disorder is cataracts. Cataracts are when the lenses of the eyes become opaque, and this may occur in one or both eyes. The cataract forms on the lens itself, and that impedes the light passing into the eye, which causes blurry vision. Typically, this occurs with aging and can develop slowly. Risk factors include age, diabetes, family history. Cataracts are also linked to exposure to UV light radiation and certain medications like steroids. When assessing the patient for cataracts, early symptoms are seeing halos around lights. The patient may have difficulty reading, changes in color vision, so color looks faded or more yellow than they should. They have poor night vision, double vision in one eye, blurry or cloudy vision, and distorted vision. Visual acuity on a Snellen chart is severely limited, usually only able to read the largest letters, and it appears as a white or gray spot behind the pupil. Cataracts cannot be treated medically. They require surgical intervention. Typically, an outpatient surgery, the patient is awake and topical and intraocular anesthesia is applied. One eye is done at the time. The nursing management for this, you're going to protect the eye with a shield for 24 hours after the procedure. Then at night and during nap time, they're going to wear the eye patch as well, or eye shield. Patients should avoid bending at the waist, as this can increase the IOP, which is the intraocular pressure. The patient should wear sunglasses and bright light. Adherence to the drop regimen, so make sure that you explain how often they should instill the eye drops, and have them return demonstration to you that they understand how to put those eye drops in correctly. So knowing how to use those eye drops are crucial. The patient should notify the eye surgeon if they have experienced any new floaters, increased redness, flashing lights, or visual changes associated with retinal detachment. Sleep, rest in a semi-phallic position to avoid pressure buildup in the eye. Disorders of the retina. Diabetic retinopathy is one of the more common disorders. This disorder of the retinal blood vessels, characterized by capillary aneurysms, hemorrhage, exudates, and the formation of new vessels and connective tissues. Approximately 80% of diabetic patients have some degree of retinal damage. This occurs more frequently with poorly controlled diabetes. Diabetic patients should have regular eye exams as earliest, and most treatable stages produce no changes in vision. Microaneurysms rupture, causing scarring and decreased vision. After enough hemorrhages occur, worsening visual acuity occurs. Best prognosis is early detection. Age-related macular degeneration, also known as AMD, is when there is damage to the macula, the part of the retina with the most acute visual perception, which allows for detailed vision. This usually occurs in both eyes, but one eye tends to deteriorate more rapidly. It tends to affect older adults, and the leading cause of vision loss in those older than 50. Risk factors include race, is more common in whites, smoking, family history, long-term exposure to UV light. It's divided in two different types. We have wet and dry AMD, which is further divided into subtypes. One of the first indicators of AMD is the loss of central and near vision. AMD is divided into two categories. You have the wet type and the dry type. The wet type, the macula becomes displaced and scarring occurs. With the dry type, is caused by degenerative changes in lipid deposits, and this slowly causes atrophy of the macular region, including the retina. You identify the AMD with ophthalmic evaluation. The main symptom of AMD is the gradual and variable bilateral loss of central vision. Color perception may also be affected. AMD assessment findings include the following. For dry AMD, you have blurry vision, which is worse with reading and doing close-up work. With wet AMD, you have distortion of vision and color changes. The medical management for this disorder, there's multiple treatments available. Diet recommendations for AMD include 2 to 3 servings of cold water fish, weekly, daily servings of leafy green vegetables. Vitamins are also recommended. Vitamins C, E, beta-carotene, zinc are recommended for AMD. Central vision damage by macular degeneration cannot be restored, but visual aids can help. AMD does not damage the peripheral vision. Early diagnosis is critical to prevent blindness. Retinal detachment. Sensory layers become separated from the pigmented layer of the retina. Typically, this occurs from a sudden blow, penetrating injury, or eye surgery. The cause is not always known. More common after the age of 40. Separation of the layers deprives the sensory layer of its blood supply. Your assessment findings for retinal detachment. Usually this is a painless disorder. Patients may complain of gaps in their vision or blind spots. They may complain of seeing flashes of light, cobwebs or floaters, and sometimes complete vision loss is even possible. Medical management requires surgical intervention. The patient may be ordered to be kept in certain positions for several days, and the head may be immobilized. Eye drops are commonly used post-op to treat this disorder post-surgical. The prognosis for reattachment is successful in 90% of the cases. Glaucoma is not one disease, but rather a group of disorders characterized by increased IOP because of obstruction of the outflow of aqueous humor, optic nerve atrophy, and progressive loss of peripheral vision, and this is common in people over the age of 60. Open-angle glaucoma, also known as primary open-angle glaucoma, is the most common type of glaucoma. The onset is slow and it develops painlessly. Vision changes occur slowly. Angle closure glaucoma is less common and it has a very rapid onset. It can lead to blindness quickly without prompt intervention. Angle closure glaucoma is considered an emergency. Normal tension glaucoma is low tension glaucoma with normal IOPs. Optic nerve damage and loss of vision still occur, usually congenital, or it occurs as a secondary response to such things as medication, trauma, or previous eye infections. Open-angle glaucoma assessment may be symptomatic or have mild nonspecific symptoms like mild eye discomfort, occasional blurry vision, halo around lights, and loss of peripheral vision. The assessment for acute angle closure glaucoma causes sudden symptoms, severe headaches, and severe eye pain. Eyes become hard and sightless, nausea and vomiting, conjunctiva is red, and the cornea becomes cloudy. Diagnostic findings: optic disc shows a cupping effect, which is a widening and deepening. There is an elevated IOP, reduced aqueous outflow, and loss of peripheral vision. Medical management for glaucoma typically uses topical medications that are dosed to achieve an optimal IOP level. Topical beta blockers such as Teminol may be used to decrease the flow rate of aqueous humor into the eye. Teminol can cause bradycardia, so use with caution. Prostaglandins help increase the outflow of fluid in the eye and reduce the IOP. Miotics constrict the pupil and pull the iris away from drainage channels. Surgical management is reserved when medications are ineffective or if the patient has poor adherence to the regimen. Laser treatment is an option if medication fails. Nursing management for glaucoma. First, you need to understand and know that acute angle closure is an emergency and requires prompt referral for treatment. Mydrotic drugs can dilate the pupil and should never be administered to clients with glaucoma. These drugs include atropine drops, so they need to avoid these type of medications. If the nurse notices this medication is prescribed to the patient, they need to bring it to the provider's attention. Educate the patient on management. They need to understand that they need to follow up and be diligent about their treatment of glaucoma because failure to do so can result in blindness. They need to know that those eye drops are lifelong treatment, so you need to have the patient demonstrate to you how they administer the eye drops and in what time they put them in so that you can see that they're administering them correctly. Tell them that they need to avoid straining for BMs. They don't need to lift any heavy objects, avoid any emotional upsets because all of these can increase the IOP and so they should be avoided. Regular follow-up appointments for an eye exam is crucial, and they need to notify their provider before starting any over-the-counter medications because some of these medications can cause dilation of the pupil. Antihistamines and decongestants can do this. Inoculation is when the eye is severely damaged and the eye may have to be surgically removed. Just like any other surgery, there's a risk for bleeding or hemorrhage postoperatively, so be very diligent in your postoperative care for this patient. Keratoplasty or corneal transplant is the removal of the full thickness of the patient's cornea and surgical implantation of a cornea from a human donor. Corneal grafts usually taken from a donor within 4 hours of death. Donor tissue is best used within 5 days. Follow facility policy for notification of potential organ donors. Our nursing interventions for keratoplasty are as follows. Discourage the patient from coughing, as this can damage the surgical site. Position the patient on their back or non-operative side postoperatively. Have the patient avoid bending, lifting, or straining for approximately 1 month to prevent increased IOP or suture tension. Report any erythema, vision loss, or photophobia to the healthcare provider, because this could be signs of tissue rejection. Use strict surgical asepsis when changing the dressing. Wash hands thoroughly before touching the eye. Limit reading. Side-to-side movement can loosen the sutures, and an eye patch if applicable. And make sure that you provide this teaching to the patient. Ears are responsible for hearing and balance. Speech development and preservation and communication are dependent on our hearing. The ear is divided into 3 areas. We have the outer, middle, and inner sections. Ear anatomy. We have the outer ear, the middle ear, and the inner ear. The outer ear collects sound waves and directs them inward. They transmit and amplify sounds as it travels down the ear canal. This consists of the pinna, the external acoustic membrane, and the tympanic membrane. The middle ear contains the eustachian tube, which equalizes air pressure in the middle ear, and this has 3 small bones, the malleus, incus, and the staples, that move when they are struck by sound waves transmitted from the outer ear. The inner ear is responsible for our balance, motion, and equilibrium, and spatial orientation. This contains the cochlea, semicircular canals, and the vestibular nerve. Terms you should know: conductive hearing loss, sensorineural, central hearing, presbycupeus, and tendinitis. Conductive hearing loss is the obstruction in the outer or middle ear, or disease in which the tiny ear bones fail to vibrate. Sensorineural is the damage to the inner ear from conditions that affect sensory hair cells or the nerves. Central hearing loss is the injury or damage to the nerves or the nuclei of the central nervous system. Pericupeus is the hearing impairment associated with age, and tendinitis is the buzzing, whistling, or ringing noises in both ears. The ear assessment should include screening, and screening should be at least every decade until age 50, and then after that every 3 years. Auditory acuity testing should also be performed. Use an otoscope to examine the ear itself. The ear canal should appear smooth and empty. The tympanic membrane should be intact and pearly gray in appearance, and it should transmit light as well. For an exam of a child, you should pull the ear down and back. To examine an adult, you should pull the ear up and back. Another way that we assess the ear is by using a tuning fork test. So we do what's called a Ryan test. The Ryan test is when you strike the tuning fork, you place it on the mastoid process behind the ear until the sound is no longer heard. Immediately after not hearing this sound, move the tuning fork behind the ear until the sound is no longer heard. Normal findings should be air conduction is twice as long as bone conduction through the mastoid. With the Weber test, strike the tuning fork and place the stem in the midline of the skull. Normal findings should be the sound is perceived equally in both ears. Click on the video embedded in this PowerPoint for further explanation of the tuning fork test. Vestibular testing, we look at the balance and equilibrium. The Romberg test evaluates a person's ability to balance. The patient stands with feet together and both arms extended, and they close their eyes. Swaying, losing balance, and arms drifting are abnormal responses. Vertigo is the sensation that a person or objects are moving or spinning. We can also do something that's called the past point testing, and this is the patient's ability to place a finger accurately on a selected point on the body. The inability to perform correctly indicates the lack of coordination in voluntary movements. So how does hearing loss occur? Repeated exposure to excessive noise, such as concerts and even work environments. Risk factors for hearing loss can be family history, congenital malformations, use of ototoxic medications such as gentamicin and loop diuretics, recurrent ear infections, bacterial meningitis, and perforation of the tympanic membrane. Age of onset can severely impact a patient's life. For example, early age when learning speech and language can lead to developmental delays. The hearing loss assessment, the key is early identification. We perform hearing test, we do a tuning fork test, history of occupational exposure to loud noises, and we obtain a family history. Medical management can be hearing aids. Some patients may need to learn American Sign Language. Patients can also learn lip reading or speech reading, and they can use closed captioning TV. Some hearing loss may benefit from surgical management. Sensorineural hearing loss is usually irreversible. If hearing aid is ineffective, cochlear implants may be considered. This is when an external microphone captures incoming sounds and the external sound processor implanted behind the ear. See the lower right hand picture of the cochlear implant. External ear disorders, otitis externa, is the inflammation of tissue in the external auditory canal. This occurs as a result of trauma in the lining of the ear. Swimmer's ear, infected hair follicle, psoriasis, or eczema and allergies can cause this. We treat it with warm soaks, analgesics, antibiotics, and corticosteroid ear medications. Teach the patient to use soft plastic earplugs when swimming and to avoid swimming for at least 7 to 10 days until the infection is cleared. Malignant otitis externa is rare, and potentially lethal Pseudomonas infection can occur. Disorders of the middle ear include otitis media, which is an inflammation or infection in the middle ear. This may be acute or chronic. Serous otitis media is associated with respiratory allergies, and enlarged adenoids is generally non-infectious. Purulent otitis media is an infectious type, and it occurs with upper respiratory infections. Complications include tympanic membrane rupture, mastoiditis, labyrinthitis, and meningitis or brain abscess, which can be severe in cases. The assessment findings for otitis media include recent upper respiratory infection or seasonal allergies, fever, tinnitus, malaise, earache, diminishing hearing, tympanic membrane looks red and bulging, dizziness, or the tympanic membrane is perforated and it causes fluid drainage into the ear canal. Management, if infectious, includes a full course of antibiotics, over-the-counter analgesics. Teach the patient to avoid using any Q-tips and avoid irrigating the ears. The most common external ear disorder is impacted serum, and this can interfere with the transmission of sounds. The patient will complain of fullness or pain and diminished hearing. Use half-strength peroxide, warm glycerin, mineral oil, or over-the-counter medications to loosen the earwax and remove it. You can use a bulb syringe, and warm water can be used. Warm irrigation is often used. Teach the patient not to use any cotton-tip swabs, so no Q-tips. If you have a foreign body in the ear, the patient usually describes discomfort, diminished hearing, feel of movement or buzzing, sounds of insect. What you'll do is, if you know that there's a bug or some type of insect in the ears, use some mineral oil, and that will smother the insect and it will make it easier to remove it with some forceps. Otosclerosis is a condition characterized by chronic progressive deafness caused by the formation of spongy bone, especially around the oval window, with resulting stiffening immobility of the staples. This is a genetic disease. Women are affected twice as often as men. Frequently, pregnancy triggers a rapid onset of the condition. This condition occurs bilaterally in 80% of the patients. There is a slow progression in hearing loss. The hearing loss can range from mild in the early stages to total loss in the later stages. Dizziness and vertigo can also occur. Both Rhine and Weber tests are performed. Medical management includes supplements such as fluoride, vitamin D, and calcium carbonate are used. Hearing aids and surgery are also other options. There is no cure, but hearing aids are helpful for otosclerosis. Vertigo is the common disorder of the inner ear. There are two types of vertigo, objective and subjective. Vertigo is the sensation of movement when there is none. It can affect balance and stability. It's not considered a disease, however, it is considered a symptom of a disease. Objective vertigo, the person is stationary and the person has a sensation that the environment is moving. With subjective vertigo, the person feels motion, but the surrounding environment is stationary. There's a spinning sensation. Treatment is based on the underlying cause. Motion sickness is a form of vertigo. It is the feeling of constant motion, and the patient may experience nausea and vomiting. Over-the-counter medications such as Dramamine and Anavert, as well as scopolamine patches, can help with motion sickness. Benign proximal positional vertigo is when there are brief periods of severe vertigo when the client moves their head, particularly towards the affected ear. This is a common type of vertigo, particularly in those in the 40 and over age group. It is sometimes related to debris in the semicircular canal. The vestibular rehab therapy can help if medications like Anavert does not. Meniere's disease is a chronic disease of the inner ear characterized by recurrent episodes of vertigo, progressive unilateral nerve deafness, and tinnitus. Meniere's disease is most common in women between ages 30 and 60. Risk factors include recurrent viral infections, stress, alcohol use, family histories, and allergies. There is no identified specific causation, but the condition is likely tied to a series of factors. The patient experienced recurrent episodes of vertigo with associated nausea, vomiting, diaphoresis, tinnitus, and nystagmus of the eyes. A sense of fullness in the ear and hearing loss may be present. These attacks last from a few minutes to several hours. Attacks may occur several times a year, and sudden movement often aggravates the symptoms. Symptoms may be sudden and may occur daily or infrequent. Vertigo symptoms of whirling dizziness when they lie down, nausea and vomiting in severe cases. Tinnitus and hearing loss may occur that last for several hours, and headaches may be reported. Hearing loss, vertigo, and tinnitus are common symptoms among disease process. When this triad is placed together, they indicate Meniere's disease. For medical management, the goal is to reduce fluid production in the inner ear. A low sodium diet, no smoking, and treatment of allergies. Drug therapy is also an option. Meclizine, diazepam, promethazine, and hydrochlorothiazide are often used. Avoid aspirin as it can cause increase in tinnitus and vertigo. Ototoxicity is a detrimental effect of certain medications. They affect the 8th cranial nerve. Signs and symptoms of ototoxicity include tinnitus, sensorineural hearing loss, lightheadedness, and nausea and vomiting. Ototoxicity is associated with the use of salicylates such as aspirin, loop diuretics like furosemide, quinidine, quinine, and aminoglycosides such as vancomycin. Tinnitus is a listed side effect in high doses of aspirin.